So the real question is, what is normal A1C? And that is dependent upon the population you're looking at. If you look on the lab slips, normal hemoglobin A1C should be 5.8. The American Diabetes Association says 7. The American Academy of Clinical Endocrinologists say 6.5. Why the discrepancy? Discrepancy is really because the ADA and the ACE both want tight control, yet don't want the side effects of treatment, namely hypoglycemia. When we first started with all these numbers, the ADA came out with 7, figuring that 7 was relatively safe, the A1C wasn't high enough to cause too much complications, and there'd be a minimum of hypoglycemia. Since we now know that A1C of 5.8 is what we need to prevent complications, the American Academy of Clinical Endocrinologists say 6.5 is better than 7, still far from the 5.8. So we want to get as close to normal as possible with minimizing hypoglycemia. We really have to adjust the A1C for age. A 50-year-old man needs a tighter A1C because his life expectancy is another 30 years. Whereas an 80-year-old man does not need as tight an A1C because diabetic complications are less likely to have a problem in the next 10 years of this man's life. So A1C has to be adjusted for the age that the patient is, his life expectancy, his comorbid conditions, and that's what the physician should be looking at. So the question is, how often should we adjust diabetic medication? And the answer is, depending on which medication you're on, will determine how soon you need to reevaluate. For example, metformin, sulfonylureas, DPP-4 blockers should all be reassessed after 2 weeks because on any given dose, the maximum response will be reached at that time. If somebody is on a TZD like Actos or Avandia, then the time between assessments should be 12 weeks because it takes 12 weeks to see the change in a single dose. If you use the injectables like Byetta and or Victoza, then you might want to check every month. So again, how often you reevaluate the patient has to do with what medication you're giving them and how bad their sugars are to change the doses or add a dose of a different medication. The last question I'm going to address is, what do you do if your A1C level is not exactly where your patient should be? And the answer simply is to keep increasing the medication and or change the patient's lifestyle so that the A1C can get down to the target you've established for that patient. If a patient is on one medication and the A1C is not where you'd like it, then you can add a second. If they're on 2 medications, oral medications, and the A1C is not where it should be, you can add a third. However, once you get to 3 oral medications and the A1C is not normal, then you have to add insulin. What I usually do in my practice is give them 3 oral pills, give them a month, and have them come back. If at that time their sugars are still high, then I add a basal insulin at bedtime, and I adjust it to achieve normal morning blood sugars. Once I've achieved that, I then do a 4 p.m. glucose. If that's above target, I get rid of all the pills and just go to shots of short-acting before meals and the long-acting at bedtime.